Okay, I think we could perhaps start as folks are joining. So welcome everyone. It's really an honor to have Dr. Gabrilove speaking this morning. And before I hand it over to Dr. Levin, just want to remind everyone to claim CME credit through the instructions Francine has posted in the chat. She'll be reposting. Yes, you can see the instructions there, which are different, right, and updated processes for claiming CME credit. So I'll hand it over to Dr. Levin, who will introduce our speaker this morning, Dr. Gabrilove.
Thank you, Dr. Campbell. Good morning, everyone. Welcome to Grand Rounds. We're very lucky to be joined today by Dr. Janice Gabrilove, who is the James F. Holland Professor of Medicine and Oncological Sciences. She serves as the Associate Director for Education and Training at the Tisch Cancer Institute and Director of the Clinical Research Education Program at the medical school. Dr. Gabrilove is co-director of our NCATS-funded NRSA pre- and postdoctoral TL1 training program and oversees workforce development for conduits. A member of the American Society for Clinical Investigation, Dr. Gabrilove is a named inventor and patent holder for arsenic trioxide, a curative therapeutic for acute promyelocytic leukemia, and for the discovery and clinical application for human G-CSF, marketed as Neupogen and Neulasta. Her clinical and translational studies demonstrated the ability of G-CSF to accelerate recovery from chemotherapy-induced and disease-related neutropenia, as well as mobilize progenitor cells into the peripheral blood. This latter observation ushered in the era of peripheral blood progenitor cell transplantation. Thank you very much for joining us today, Dr. Gabrilove.
Thank you so much for that absolutely lovely introduction. I hope you're still pleased with my joining you today at the end of this talk. But thank you, everyone, for joining us this morning. I'm going to share my screen. And what I've been asked to discuss this morning with you is really chronic lymphocytic leukemia, from bench to bedside and beyond, since our knowledge and the rapid evolution of understanding of this disease and targeted therapeutics directed and informed by the emerging science is really moving at a rapid pace. I hope you'll be sufficiently impressed that the way in which we are actually approaching this disease today is very different than even a year ago or 2 years ago, let alone 10 years ago. And what we will be recommending in the future will be further informed by that emerging knowledge. So I have no financial conflicts of interest to declare for this presentation. Oops, sorry. We're going to take a little bit of a whirlwind tour and get our ducks in a row. We're going to start with a definition, incidence, and risk, as well as genetic susceptibility in CLL. We'll talk a bit about the clinical presentation and complications. We'll review from an aerial perspective the pathobiology and pathogenesis of this disease as it's rapidly emerging. That in turn has informed disease classification as well as prognostic variables and risk stratification. And finally, this new science has informed our therapeutic approaches. So we have a lot to cover in small bites, and we'll try to do this with ease. So let's first start with the definition of the disease, because for many of you, this may come as a surprise that that definition has actually changed in recent times. So chronic lymphocytic leukemia, of course, is the most common leukemia in the Western world, making it about 10,000 cases per year. It's the most common B-cell leukemia in the US. It's common in 80 aging individuals with a median age of 66 years. And 90% of the cases occur in persons older than 50 years. The disease is one of impaired programmed cell death defined by the accumulation of CD5, CD19, CD20, and CD52 HLA-DR mature appearing lymphocytes with dim surface immunoglobulin antigen expression. It's varied and often long history, extending for months or decades. So as I mentioned, this disease is really a proliferation and accumulation of CD5, CD19, CD20, and CD52, CD23, and HLA-DR positive B cells in the blood and bone marrow, as well as lymphoid tissues. And I mentioned the phenotypic characteristics of this disease because there are related indolent lymphomas that share some antigenic features in common with CLL, but it's this unique combination that is the way in which we recognize this phenotype as determined by flow cytometric analysis. Currently, or in the past, one assumed that if one had an absolute lymphocyte count of more than 5 × 10⁹ cells per liter, that this was very likely to be consistent with CLL. However, that no longer is the case in terms of the diagnosis. The diagnosis actually requires the presence of more than 5 × 10⁹ cells per liter of monoclonal B cells of the typical phenotype described above in the blood. So it's not just the absolute lymphocyte count, it's actually the number of monoclonal B cells that really determine this diagnosis. Patients with lymphocytosis of more than 5,000 cells per microliter circulating CLL-like cells may actually have small lymphocytic lymphoma if in fact they have the presence of lymphadenopathy or organomegaly or other evidence of extramedullary disease. But if none of that is present, then actually these patients turn out to be monoclonal B lymphocytosis as long as they have no additional findings. So in the current diagnosis of CLL, a lymphocytosis itself may turn out to in fact be CLL if more than 5,000 cells turn out to be monoclonal in nature. But if that's not the case, we now refer these two as monoclonal B lymphocytosis, which can be a precursor as depicted here. So CLL is really thought to be a spectrum of disease, starting with this monoclonal B lymphocytosis, and then over time, in some instances, progressing to frank CLL. So what is monoclonal B cell lymphocytosis? It's a CLL clone that's actually detected in otherwise unaffected individuals on 0.14% in blood donors and 3 to 5% in adults, non-hematological patients in outpatient clinics are the estimates. It's more frequent in older individuals, and the protein expression profiling of these cells demonstrates phenotypically to be identical to CLL cells. There's a higher incidence of detecting these cells in the first-degree relatives of CLL kindreds, and the clinical presentation is typically silent and persists for more than 10 years. A small percentage will actually progress to frank CLL. So monoclonal B lymphocytosis is also characterized by no risk of infections or hypogammaglobulinemia, which we'll learn is something that we do see in frank CLL. These patients actually can have specific chromosomal abnormalities, observed specifically deletions of 13q14 or trisomy 12, but do not have a loss of p53 exemplified by 17p deletions or changes in ATM as evidenced by 11q-. We divide monoclonal B lymphocytosis into two categories, high count versus low count, and the function of the absolute B lymphocyte count of more than or less than 5,000 B cells per microliter. Now, low count monoclonal B lymphocytosis is 5% of adults and greater than 40 years of age, and it rarely progresses to CLL. In contrast, the high count monoclonal B cell lymphocytosis is the one that does progress. So CLL is, as I mentioned, the most prevalent type of leukemia in Western countries, 4.9 cases per 100,000 individuals per year. The incidence rates in men is twice as high as in women. Recently, there's been an observed decline in incidence, which may be related to some of the risk factors, such as chemical exposure with the use of hair dyes, harking back to the 80s, and pesticides, many of which are no longer allowed to be utilized. Related to that chemical exposure, professions such as farming, landscaping, and hairstylists have a greater risk of developing CLL. Additional risk factors include white ancestry, and as I mentioned, first-degree relatives with CLL, and a family history of any hematologic malignancies, with a 2 to 8-fold increase in developing the disease among those individuals. So given this familial increase risk, there have been a large number of studies looking at genetic susceptibility. And GWAS studies have identified 45 susceptibility loci. And these loci, as indicated on this cartoon with these triangles, orange triangles, occur largely in non-coding regions. But 93% of those susceptibility loci lie within regions of active promoters, as implicated here, within regions of active promoters or enhancers, resulting in modifications of transcription factor binding. And that is exemplified here, where we have disruption of 2 types of pathways, specifically NF-kappa B in particular, and increased affinity of these transcription factors families as a result of these particular susceptibility loci. This in turn will lead to some of the genetic basis for the underlying pathophysiology of CLL, which are changes in immune response, enhanced cell survival, and the ability to minimize regulatory mechanisms to enhance or allow for programmed cell death. So these aberrations impair programmed cell death and enhance mechanisms for Wnt signaling to allow for cell survival and enhanced proliferation. There are other loci that have been noted for genetic susceptibility, and they involve POD1 mutations, polymorphism in phase 1 and 2 xenobiotic metabolizing genes, and DNA damage polymorphisms, which contribute to this phenotype. So let's switch gears a little bit and talk about the clinical presentation and some of the complications. So first and foremost, the most common presentation for this disease is the asymptomatic individual, where there's an incidental finding noted with the presence of lymphocytosis on a routine blood count. Symptoms include fatigue, which are often attributable to many other conditions. Other B constitutional symptoms that we sometimes see in more advanced disease, as we'll talk about, include fever, night sweats, and weight loss. Adenopathy is also a feature of this disease. Infections, particularly those of encapsulated organisms, as we'll learn about, sinusitis, bronchitis, pneumonitis, otitis, and rarely meningitis. Again, infections related to encapsulated organisms, not just generic infections. And then early satiety, which is related to splenomegaly and sometimes associated with left shoulder pain, again, related to capsular stretching with splenic enlargement. Some of the clinical complications of this disease, and we'll talk a little bit about why that occurs, is hypogammaglobulinemia, specifically IgG3 and IgG4. And again, this contributes to these infections with encapsulated organisms, giving rise to potential indications for immune globulin, which would be, in the current guidelines, recurrent or documented evidence of a bacterial and encapsulated organism, bacterial infection in the sinus or pneumonia or otitis, which would then warrant, in the presence of hypogammaglobulinemia, the institution of IVIG. Bronchiectasis is a real complication from hypogammaglobulinemia, but even in the presence of therapy, recurrent injury to the small airways can lead to bronchiectasis, which becomes a chronic problem for these patients. Skin cancers, particularly non-melanoma type, although melanoma is also observed, 8 times more likely than in non-CLL patients. And so patients with CLL need to be counseled for the importance of screening and the importance of prevention strategies. Also increased are unusual skin cancers, including Merkel cell carcinoma. Myeloid malignancies in the long term are also associated with CLL, and in particular, myeloproliferative neoplasms and acute myeloid leukemia. In fact, in patients with CLL who have evidence of marrow involvement and other lineages affected, one of the clues to possibly having a concomitant myeloproliferative neoplasm is actually a normal hemoglobin, which in the context of other disease findings would be expected to be lower than you actually observe in a given patient, potentially launching the concern for evaluating for an occult myeloproliferative disease complicating CLL. Other clinical manifestations and complications include anemia, and anemia can be multifactorial or be due to different causes. Anemia of chronic disease is exemplified in this condition and is the classic mechanism of action. But autoimmune phenomena are also a hallmark of this disease. So autoimmune hemolytic anemia, which can be of the warm and complement binding type versus cold agglutinin disease. And finally, pure red cell aplasia, where there's a paucity of red cell development due to overactive robustness on the part of T cell interactions with the B cell clone, leading to specificity spillover, if you will, and suppression of erythropoiesis. Thrombocytopenia from ITP, again, a manifestation of autoimmune phenomena, as well as other autoimmune disorders, including channelopathies, which are rarely seen but are observed, including limbic encephalopathy. So individuals with CLL who have altered mentation, cognitive impairment, or early signs of dementia really need to be evaluated for the possibility of limbic encephalopathy. There's often a classic MRI appearance, although MRI appearance may not be visualized. And so sometimes one needs to resort to actually intervening in the disease to see if this actually resolves. There are paraneoplastic antibody panels to assess for this, but their positivity is not required for this clinical diagnosis. Additional features to look for in these patients, the vast majority of these patients actually have vitamin D deficiency, which requires replacement and may contribute to their infectious risk. A number of unusual cutaneous manifestations, such as arthropod or bullous pemphigoid-like reactions that are forms of eosinophilic dermatosis, and then infections with specific viruses such as A. zoster and CMV infections. So we're going to switch gears and talk a little bit about the pathobiology of this disease. And we're going to spend a little time talking about the B cell development and CLL cells of origin. We now know that this disease is at least a disease of 2 types of B cells, if not 3. We'll talk a bit about the B cell receptor structure, which is composed of immunoglobulin molecules and the CD79A and B subunits, and why that's important, since that appears to be one of the critical components in CLL. We'll talk about the B cell receptor VHCDR3 stereotyping, which is the biased use of specific immunoglobulin heavy chain variable genes and the role of common antigens in the evolution of this disease, a bit of B cell receptor signaling, and microenvironmental influences. I'm just going to, my light goes off when I'm sitting still in my room, so I need to wave my hand, so I apologize. So this cartoon really tells us something about the B cell receptor maturation during B cell development. B cells undergo a series of maturation steps in the bone marrow that lead to the generation of a mature B cell, which express both IgM and IgD as part of their structured B cell receptor. So this cartoon is the B cell receptor. Early on, it's comprised with IgM and subsequently IgD with the CD79 subunit on this component. And this comprises the B cell receptor. B cells then continue their maturation by going to school, if you will, in secondary lymphoid organs, including lymph nodes and the spleen, where the antigen encounter, the B cells are further diversified through somatic hypermutation and class switch recombination. And that's cartooned here, where these B cells will enter the spleen, initially in the marginal zone and then into the germinal center, where they undergo somatic hypermutation and become memory B cells. And these memory B cells have undergone changes within the immunoglobulin region to allow for antigen interaction. And these become memory B cells. In some instances, those cells can also further diversify through class switch recombination arising from distinct precursors that will change to IgG. So CLL actually reflects two different stages here, stages where unfortunately, we use the term unmutated, which is a natural mutation process that just refers to naive B cells that never undergo somatic hypermutation. And those are really thought of as earlier cells, whereas a more mature memory B cell phenotype is referred to as a mutated CLL cell. And we know that the disease really at least occurs in these two different phenotypes, and they have drastically different risks and potential outcomes, and are associated with different genetic alterations. So just to take a little deeper dive into this somatic hypermutation within the B cell receptor, I thought it was helpful just to remind us about what the B cell receptor looks like. Again, we have this CD79 A and B subunits, and then the immunoglobulin portion, which is made up of both light chains and heavy chains, common as well as variable. And it's this variable region of the heavy chain gene that undergoes this VDJ recombination that gives rise to the diversity of antigen binding sites. And this is just characterized in a little more detail here, that we have this VDJ joining regions, and specifically this CDR3 region that is responsible for antigen binding. And what's particularly interesting in CLL is that the selection of these CDR3 combinations seem to be stereotyped. There's a bias in about 30 to 35% of patients to use similar recombination events or to lack recombination events in this particular region, suggesting that there are a range of common antigens that may be drivers of this disease in the first place, as yet to be determined. And so we have unmutated CLL where these cells have not undergone somatic hypermutation, and mutated CLL where they have, and the mutated CLL representing memory B cells and unmutated CLL cells representing naive B cells. And these cells, the frequency appears here, 40% of unmutated phenotype versus 60% in mutated. Homology with germline IgHV, of course, in the unmutated, complete homology, whereas these have undergone this somatic hypermutation and so not. B cell receptor responsiveness is high, meaning that it's constantly turned on, whereas these are less responsive to external stimuli. And the clinical outcome, largely, although this is changing, is much worse in unmutated CLL. And the clinical course, one that we're often used to thinking about in CLL when individuals, perhaps inappropriately so, use the term the good leukemia, is the fact that this particular phenotype is often more indolent. Of course, none of this represents a good leukemia. So in addition, we've learned a lot about how the B cell receptor engages with the outside world or is prone to stimulation. And these messages are then carried through secondary messages linked to the B cell receptor. And these include secondary messengers such as SYK, BTK, PLC gamma, leading to both PKC activation, the ERK pathway, and NF-kappa B. And as we'll learn a little later and indicated here, based on this pathobiology of the B cell receptor and the downstream events that then lead to enhanced survival of cells and impaired programmed cell death, as well as increased proliferation through these signaling cascades, have led to the targeted therapeutic approaches and informed those strategies. And we'll learn about that a little further on. So CLL cells, as is true for all cells and malignant cells in particular to think about, don't live in suspension, but they rather live in the context of a microenvironment. And this is a simple cartoon that just demonstrates the importance of the malignant CLL B cell, whether it is residing in the lymph node or in the bone marrow and microenvironment, comes into contact with cells within that milieu, including fibroblasts, endothelial cells, T cells, and macrophages, and are responsive to a variety of chemokines, adhesion molecules, cytokines, as well as growth factors that will enhance the malignant phenotype and its ability to survive and proliferate. This is an additional cartoon that just further exemplifies the CLL cell niche composition, which includes B cells, T helper, cytotoxic T cells, and regulatory T cells, as well as a variety of stromal cells and nurse-like cells. And these cells, in turn, enhance, based on the malignant phenotype, further reinforce the survival advantage of these cells, enable them to home to niches within the bone marrow and lymph nodes, impairs their migration to other sites, and contributes to drug resistance. So this is a simplified version of looking at cytokine effects in that large milieu within the microenvironment. We've actually spent time in the past studying the influence of specific cytokines on CLL survival. And this divides us into cytokines that induce proliferation in CLL cells, may actually induce differentiation, and by doing so may serve to extinguish self-renewal and the ability of these cells to extinguish the clonal abnormality by forcing cells to terminally differentiate, and other cytokines that will actually prevent programmed cell death or apoptosis. And some of the treatments that we still use, but use far less often, as well as ones that we now use commonly, such as IMiDs, that actually work by inducing programmed cell death, trying to overcome the influence of these specific cytokines in that context. And this is data taken from studies we did a considerable time ago and published in Blood, just to highlight the point that it's not just the microenvironmental cells that provide some of these signals to enhance survival and prevent apoptosis and contribute to drug resistance, but the CLL cells themselves have a capacity to have autocrine production of a variety of these self-serving cytokines, if you will, to provide additional advantage. And this is just an immunofluorescence looking at endogenous basic FGF levels in CLL patients, low risk, intermediate, and high risk as compared to background. And you can see there's a considerable increase as demonstrated by this immunoassay on this field, where we're looking at normal B cells compared to low risk, intermediate, and high risk by the modified Rye classification. In terms of the amount of basic FGF, one of those cytokines that contributes to increase survival of CLL cells. So just to summarize this portion of our discussion, CLL is a B cell receptor dependent malignancy. B cell receptor signaling is a central pathway promoting impaired programmed cell death and proliferation of CLL B cells. 30 to 35% of CLL patients express a largely skewed immunoglobulin repertoire with virtually identical B cell receptors, so-called stereotyped receptors. They have virtually identical variable heavy complementarily determining regions responsible for interacting with antigen, and microenvironmental factors contribute to CLL cell survival, propagation, and to immune dysregulation. So let's spend a few moments talking about the molecular genetics of CLL as we build some of the features that contribute to both good outcomes and not so good outcomes. So this is taken from a paper by Halleck and colleagues looking at a word cloud. These are genes and chromosomal regions affected by molecular lesions in CLL. And of course, the font is proportional to the frequency of the molecular lesions. And you can see that there's a plethora within this cloud of alterations. But the ones that come to the fore are the ones that have really entered into the clinical arena in terms of prognostication. So chromosomal abnormalities in CLL are really 80% of patients carry one of 4 common chromosomal alterations. I should say that typical cytogenetic karyotyping requires cells to be actively dividing, and this hampered the delineation of chromosomal abnormalities in CLL because although there is a proliferative component, it is a tiny fraction of the CLL clone, which is largely resulting from cellular accumulation. And so these cells are often not in the dividing state. However, with the advent of fluorescent in situ hybridization or FISH techniques, which allows one to look for chromosomal abnormalities in non-dividing states, this greatly advanced our knowledge to really delineate these 4 common chromosomal alterations. So the first is deletion in 13q14, which is observed in 50 to 60% of patients. And again, this can also be seen in monoclonal B cell lymphocytosis, both the low count as well as the high count, the latter being the one that has the opportunity to progress to CLL. This deletion involves the loss of microRNAs that are regulators of programmed cell death and cell cycle, that actually they regulate by allowing for apoptosis. So their loss actually impedes programmed cell death. And in turn, this results in upregulation of BCL2, which in addition impairs programmed cell death. A second is deletion of 11q22.223, and this involves the loss of the ATM gene. Deletions of 17p12, which is a chromosomal deletion of a copy of p53, and trisomy 12. In addition, there are a number of mutated genes and pathways in CLL that we have discerned over time. And while I'm not going to go through the litany of mutations, as there are a number of them, it's important to just note the category in which these mutations arrive that are considered to be driver mutations. Notch signaling being one very important one. Mutations in B cell receptor and toll-like receptor signaling, with mutations in the B cell receptor contributing to further ability of the B cell receptor to be auto-stimulated, if you will. MAP kinase and ERK kinase pathways, NF-kappa B signaling, RNA splicing mechanisms, DNA damage, cell cycle, and chromatin modifiers, with the major contributors being in the realm of NF-kappa B signaling, Notch, and DNA damage. And this just demonstrates again here from a cartoon these points of interest in terms of NF-kappa B, toll-like receptors, and Notch, DNA damage response, and programmed cell death, where these mutations actually arise within the cellular machinery. So these mutations in particular genes, on this side of this panel, we see the number of affected patients in this particular study published in Blood in 2015. You can see that the most common mutations in this particular population of all comers included p53, ATM, and SF3B1 splicing gene. And you can see on this side, here we're looking at the type of mutations that occur, with missense mutations being the most common in this particular, sorry, my mouse is very sensitive, sorry, being the most common type of mutation that's observed. These are circular depictions of the association of IGVH unmutated phenotype with some of these particular mutations, and you can versus mutated CLL phenotype. And you can see that the unmutated phenotype is more commonly and much more strongly, as indicated by the width of the bands, and disadvantaged by observing mutations in ATM, Notch, p53 much more regularly in unmutated as compared to the mutated counterpart, which is associated with splicing alterations and toll receptor. But even in those cases, a much weaker association as opposed to the strength of these associations. Again, leading to the difficulty in the biology of unmutated CLL versus mutated disease. Other cytogenetic abnormalities, this is just an association of cytogenetic abnormalities, again with these specific mutations, and just demonstrates that the 11q and 17p, which are adverse prognostic features, are much more commonly associated per se with some of these altered mutations. So we're going to switch gears one more time, and we're going to talk about staging, indolent versus aggressive, and Richter's transformation. So staging of disease, there are really three ways we stage this disease. The Rye classification, which is the traditional staging of stages 0 to 4, as well as the modified Rye that condenses this into 3 stages of low, intermediate, and high-risk disease. I will say that a lot of the older studies and even some of the more recent studies until the diagnostic criteria for CLL were changed, many patients with monoclonal B cell lymphocytosis were actually included in the prior stage 0 disease. And so that analysis requires further updating. The modified Rye also is based on blood counts and physical exam. And then the Binet, which has 3 stages that are based on number of lymphoid sites, hemoglobin and platelet values, and splenic form of disease. And you could say, well, why didn't we just stay with these? Well, the problem with these is that, of course, low-risk disease, while normally doing very well with on average not requiring treatment for 11 years, there were still patients who within 1 year required treatment. And suffice it to say that there were outliers in the high-risk group that appeared to be expected to do very poorly within 2 years, but who went on to behave more as if they had low-risk disease. And this really underscored the need to further refine this classification. So currently, the CLL International Prognostic Index really takes into account factors that have come to the fore for evaluating disease. And in this particular scoring system, we have age, clinical stage, which comes into play, beta-2 microglobulin levels, which has to do with the size of the disease, of an estimate of the disease involvement, the size of the clone, the IGVH mutational status, and the P53 status, whether it's due to a gross deletion or a mutation. And this then codifies 4 risk groups, which were developed to predict overall survival as well as time to first treatment. And it divides it into 4 groups: low, intermediate, high, and very high, with the overall survival being quite good in the low and intermediate, beginning to drop at 10 years in high and certainly very high. Suffice it to say, these numbers are in evolution. With the advent of new therapies, we need to go back and really look whether these still hold true, since some of these numbers are really generated from therapies that we don't necessarily use in the current time. The German CLL study group also further refined this CLL IPI and looked at additional markers, including serum thymidine kinase, not only above or below a certain level, but really evaluated a gradation of beta-2 microglobulin level to be considered, included physiological assessment of well-being which is the ECOG performance status, added in deletions of 11q, as well as male gender. And based on these additional markers, they divided into 4 risk groups, which have very comparable numbers to what was seen for the IPI score. In clinical practice, you should be aware that we use a number of features. This is a cumulative illness rating scale to evaluate the presence of comorbidities. And there are a variety of other markers that we use, ZAP70, CD38, which is really a poor man's version of IGVH mutational status, and some additional chromosomal abnormalities, which have turned out to be prognostic, but not necessarily predictive. So if we think about then putting some of this together about the behavior of CLL, we have monoclonal B lymphocytosis that can progress to CLL. They have similar features, but only some additional mutations that can occur, such as in Notch1 and P53, can then enrich for the possibility of evolving to CLL. And it's the presence of those drivers that's associated with a shorter progression, in particular in the high count monoclonal B cell lymphocytosis. In frank CLL, there are reports of spontaneous regression, and this just looks at white blood count as a surrogate for lymphocyte count over time. In this instance, there's low proliferation and migration. It's always in the case of mutated immunoglobulin heavy chain gene phenotype CLL, the absence of any stereotypes, and reduced T cell exhaustion and increased T cell proliferation. Then we think of the logistic growth, which is the most common, and this is a long lymphocyte doubling time. It's commonly seen in mutated phenotype. There are a low number of these driver mutations and very little in the way of clonal evolution. And this can go on for considerable periods of time, 10 years or more. And then the exponential growth phase, where there's a short lymphocyte doubling time, much more commonly seen in the unmutated phenotype. There are high numbers and evolving number of driver mutations. And then finally, the risk of progressing to diffuse large B-cell lymphoma or Richter's transformation, which can also include progression to Hodgkin's disease, that is associated with, again, specific driver mutations, additional complex karyotypes, the acquisition of additional drivers in MYC and cyclin specific genes, as well as in particular stereotype subtypes, specifically subtype 8. So lastly, I'm going to close with just talking about some therapeutic approaches. And I just want to highlight some take-home points from this portion of our discussion. Treatment paradigms have dramatically changed. The initiation of treatment is really guided by the notion of active disease, as indicated by the International Working CLL guidelines. We utilize risk-based algorithms to drive treatment choices. Targeted therapeutics are aimed to disrupt altered signaling, to address the impact of many of these driver mutations, as I've tried to show you in our overview of pathobiology, and immune dysregulation. Immunotherapeutic approaches are directed at specific antigenic determinants with the use of monoclonal antibodies and CAR T cells. And traditional chemotherapeutic approaches aim to induce programmed cell death and impair aberrant T cell responses and DNA damage, still play a role but have a more limited application and are largely not the mainstay. So this is taken from blood, the management of early stage CLL and its related counterpart, small lymphocytic lymphoma. A newly diagnosed patient would undergo risk stratification and counseling. Patient-related factors would be noted and CLL-related factors, recommendations for health screening, including annual skin exam, vitamin D deficiency evaluation and treatment, and age-appropriate cancer screening. Certain infection prevention include vaccinations for influenza with high-dose influenza vaccination, even in younger individuals, pneumonia vaccination, the avoidance of live vaccines, and immunoglobulin if IgG levels are less than 600 and recurrent bacterial infections have been documented. As I mentioned, the International Working Group for CLL defines active disease by the presence or one or more of these following criteria: marrow failure, progressive symptomatic splenomegaly, adenopathy, that is from which patients are symptomatic, progressive lymphocytosis with an increase of greater than 50% over a 2-month period, autoimmune phenomena, symptomatic or functional extranodal involvement, and constitutional symptoms. In the absence of these, there really is no indication for initiating therapy. So our armamentarium has been informed by the plethora of data now on the pathobiology and pathogenesis of the disease, and again is directed at particular features or specific mutations derived thereof. Antibody strategies, with the leader being rituximab, are really directed against CD20, with additional second and third generation antibodies that have shown additional promise over rituximab itself, as well as antibodies to CD37. Strategies to really look at blocking the B-cell receptor downstream targets, specifically BTK inhibition, with the use of BTK inhibitors, the classic drug being ibrutinib or Imbruvica, and the second generation acalabrutinib, with a number of third generations on the way that are designed to enhance affinity to BTK, as well as reduce off-target effects observed as side effects with these drugs. Drugs that target the PI3 kinase, exemplified by idelalisib. Cell-based therapies directed against a different antigenic determinant, CD19, and these are largely cell-based therapies or CAR T cells. And then the downstream effect of many of these mutations that impact these pathways result in overexpression of BCL2, and that has become a potent target directed by venetoclax. In this particular instance, venetoclax being really exquisitely sensitive for CLL cells as opposed to other tissue targets. This is data taken from the Kaplan-Meier curve for the first trial of ibrutinib versus standard of care chlorambucil in patients over 65. And suffice it to say, this demonstrated patients with progression-free survival considerably more. This RESONATE-2 trial has now had a more than 5-year follow-up where this difference is maintained, and consistent benefits been observed even in high and very high prognostic groups. And just in closing, this just gives you a feel for the algorithms that we use, the clinical situation, the P53 aberrations, the mutational status, the presence of comorbidities and age that will inform whether they're absent or present. In this case, in treatment-naive disease, P53 absent or present. If it's absent, the mutational status, how that informs, versus if it's present. And you can see just from the treatment approaches, largely these new small molecule inhibitors have replaced standard chemotherapy as the first treatment of choice. So in closing, the key take-home points are that CLL is not the good leukemia. The definition of CLL has changed. Monoclonal B cell lymphocytosis can be a precursor of CLL in the high count form. Genomic analysis has provided insight into disease pathogenesis, the drivers of clonal evolution, and potential targets for therapeutic manipulation. Classification, risk stratification, and prognostic variables guide medical care, and therapeutic approaches are changing rapidly. And with that, I'll stop sharing my screen, and in the few moments remaining, be happy to entertain any questions or comments.
Thanks so much, Dr. Gabrilove. Yeah, that was great. Thanks for sharing. So encouraging everyone to enter questions in the chat. I guess just one I had just was regarding the large genetic component, right, to disease pathogenesis. I guess these are mostly somatic mutations, I would assume, rather than germline. And just to follow on that, I guess there's some population level data with disease burden, by geography around the world, and what can we glean by the variable disease prevalence in that regard? Is it more environmental, or is there more of a germline component?
So great questions. I may not have all the answers to them. So these are somatic mutations, not germline mutations. The susceptibility loci are, germline based on GWAS studies. But not the specific types of mutations that I talked about. Those are somatic mutations that accumulate over time. Now, whether there's a greater predisposition in people who have specific genetic susceptibility, that I don't know. And I haven't seen any literature on that, but it could just reflect my lack of knowledge. There is data to suggest that, if you look globally, that certainly Western countries have a much higher incidence than countries in Asia or in Africa. And this is true even, so there have been studies to look at people from Asia migrating to the United States. They maintain that lower risk. So there is some genetics there that is not, or some protective factors that is not well understood, or I certainly haven't seen any literature. I did try to look actually a little bit for that in preparing for this talk, but I'm not aware of that.
Thanks so much.
Yes, those are your questions.
That was great. That was great. Yeah, there are two more in the chat. Dr. Gallagher was asking about whether vitamin D deficiency is a risk factor for CLL, or whether that's secondary to vitamin D uptake by the vitamin D receptor on B cells.
So it's thought to be secondary to uptake by the vitamin D receptor on B cells. And actually is something that we see in all lymphoid malignancies, and have become very cognizant. What's not known, and there are studies ongoing, but the data is not in, and again, I tried to find this for our discussion today, whether correcting vitamin D deficiency in any way changes the outcome of disease. There is certainly a hypothesis that it may influence infection risk, especially viral infection, but that's really not known. So we don't have that. We don't have the answer to that. There was a question about unmutated versus mutated genotypes differentially responsive to different agents. So in the era of targeted therapeutics, this is one of the areas that is emerging. In general, patients with unmutated phenotypes in the past in response to chemotherapy, standard chemotherapy regimens, did poorly. In addition, patients with p53 abnormalities, be they gross chromosomal deletions or mutations, point mutations, were not responsive to standard chemotherapeutic approaches, and it was not recommended. But in the era of targeted therapies, that's where this needs to really be the weight of the data. We're not quite there yet in terms of really looking how this holds up in terms of responsiveness to treatment. There's responsiveness, and then there's duration of response, risk for mutations in BTK receptor, for example. Is that more common in unmutated versus mutated? There are some small series to suggest that unmutated still is a disadvantage, but the weight of the evidence is just not there yet that I'm aware of.
It's great. I think just one last question is regarding the vitamin D level that you'd recommend for CLL patients.
Normal range. The normal range. I mean, the regimens are all over the map. I use some advice from my endocrine colleagues, but we usually we treat any level that's below normal. So I know in primary care, people who hover around the normal range are not necessarily replaced, but we go ahead and replace them. So we usually replace with 50,000 units weekly, times 4 if their level is just below the normal range, and then switch to 2,000 units, vitamin D3, daily. If they're very low, if they're half the normal range, 50% lower than the lower end of normal, then we will give them 50,000 units for 8 to 12 weeks and then switch to the daily replacement. And we monitor their levels as their disease improves. If their level remains normal, we back off and still monitor. And I think those are among the recommended NCCN guidelines and IWCLL guidelines.
All right. Thanks so much, Dr. Gabrilove. That was great and very informative. Thanks again.
Good. Thank you. Thank you for having me. Take care. Have a great day, everyone.
You too.